All right. I hope everyone online can see the slides and can hear me okay. Yeah? Is it?
I think, Emily, you have to change the view.
That's what it looks like to me also. Yeah. Do you know how to do it? Well, maybe there's nothing wrong with giving you the preview, but. Just if you share.
Go to the display setting. Go to the display setting. Then it will. Go to the display setting.
Display settings. I think
No. Put up the slide first and then put up the slide.
Yeah.
Then go for the full view. Presentation mode. Presentation mode. Go to the presentation mode.
I can call multimedia.
Go to the presentation mode.
Go here. Wait. Do you know how to do it?
Go to the.
Okay. Yeah,
go to the.
I'm following that.
Please.
You're sharing the wrong screen.
Go to the presentation mode, then that will come up.
Okay.
Having problems in Sheldon. They're on the way.
Can you hear me, Emily? Emily, can you go to the presentation mode?
I can hear you. I can hear
Okay.
you. It's not going in. Well, it's not going for some reason.
Then you have to upload again. Yeah, share it again.
It's a shame here. Let me try this again. Hold on. Is this mine? No, this one. Okay.
Then go up on the left side, say display setting, and click on that. And you swap the presentation view. Good, it's getting done.
Doesn't quite work for us here. But so online, are they seeing just this? Yeah. Okay. Should we make the compromise that the audience sees the notes and online you see the real thing?
Yes,
Great.
yes, this fine now.
Yeah. Okay, great. All right. We have to be adaptive, right? We have to go with the flow. Okay. Well, again, thank you so much for organizing this seminar. It's really exciting to be here and particularly to be connecting with colleagues online from around Asia, but including Kerala. And really, I put together this talk with you in mind. So I want to talk about finding and investigating Nipah virus spillovers. And I want to talk about the difficulties of doing that, how we've approached that in Bangladesh, and the promise of what we gain from doing that very difficult work. Since I'm the first speaker today, I'm going to just take a moment to say why we care about Nipah virus. There are so many public health problems in the world, so many public health problems in our communities. Why in the world would we spend so much time and energy on a disease that causes, some cases, okay, a few deaths here and there, but nothing compared to many other infectious diseases even that happen in Asia. I think there are some good reasons why we still care about it. It's highly fatal with a very quick progression, and so outbreaks, even though they're relatively rare, still relatively small for the most part. They're very distressing for the communities themselves and for responders. It's hard not to be involved in an outbreak like that and not be very compelled to action. There are no approved treatments or vaccines. That also plays into the high case fatality, but it also means that you're feeling a bit like there aren't many tools at your fingertips to respond when an outbreak occurs. There are multiple demonstrated pathways of transmission for Nipah virus, okay? So it's been transmitted from bats to pigs in Malaysia, from pigs to people. In Bangladesh, it's transmitted directly from bats to humans. The receptor binding site for the Nipah virus is highly conserved across all mammalian species. So almost all mammals can be infected with Nipah. So this tells us that this virus has a lot of tricks. It has so many opportunities to try to advance itself in the world to our detriment. So this is another reason why we care. And finally, of course, it can be transmitted between people. This is really the issue. This is why we see larger outbreaks, mostly because of the person-to-person transmission. And this is why there's some concern about Nipah as a pandemic threat. So that's why we're here. When I talk about spillovers, I just want to be clear about what I mean. This figure comes from a colleague of mine, Raina Plowright. And it just shows all the things that the virus has to do. It has to somehow manage to get through all of these layers for one spillover to occur. Pteropus species fruit bats are the reservoir host for Nipah. They're distributed throughout Asia. As I mentioned, the receptor binding sites for that virus are widely conserved. So there's high susceptibility across mammalian species. So it can infect mammals. Those other mammals like pigs could be a bridging host. It can directly infect us as well. So when I talk about Nipah spillovers, this is what I mean. That event, somehow when a human is newly infected from an animal. So I'm going to talk first about difficulties. I remember very clearly when the first outbreak from Kerala was first reported. I was on my way to a Nipah meeting, actually, and I thought about people in Kerala, and I had some idea of probably what they were thinking and what they're experiencing. I'll take you back about 20 years. So in 2003, was when I started working at the ICDDRB in Dhaka, Bangladesh. This is what it looked like in 2003. And that's when I began my career really as an epidemiologist, I would say. I'm American. I look quite typically American. A little part inside is Bangladeshi. I spent most of my career there, and my work is still focused there. In 2004, I was here, just about 20 years ago today, and this was the first Nipah outbreak I ever investigated. This is a photo that I took. This is my colleague, Jahangir Hussain. Our job was to try to figure out what the outbreak was. We didn't know it was Nipah first, right? How do you know? How do you know until you do the diagnostics? It took us weeks to find out then because there was no diagnostics in country. But it was our job to figure out how it was happening. So I understand really how difficult it is to try to figure that out. At the time when this outbreak happened, we knew that the bats were the reservoir hosts. We knew that pigs had been infected and that they had infected people. There had been 2 other outbreaks in Bangladesh, but we didn't really understand how transmission had happened at that time. Okay? There was we were looking for contact with sick animals. So there had been a sick cow involved somehow in one of the outbreaks, but we really didn't understand what was going on. So what did we do? We looked at the bats, of course. We spent a lot of time talking with people. So you can see here, so people that we saw every day for weeks. We became very good friends. Obviously, we have to know everything that was happening in that village at that time to try to reconstruct and to develop hypotheses about how transmission was happening. We came away with two major hypotheses. Well, we had dozens, and we used case control studies to test all of those hypotheses. How are the cases different from the controls? What exposures did they have that were different? We were interested in fruit, consumption of fruit. These are buroi, locally called, they're jujubes. And many of the children infected in this outbreak had been climbing in a jujube tree. And then we also saw this. So this is another great way for humans and bats to come into contact. It's a date palm tree, and they collect sap and they drink it fresh in the morning. So we had all this list of hypotheses, and we tested them in our study. And at the end of the day, we said, well, the cases were more likely than contacts to climb trees. We didn't figure out how the outbreak really happened. There were only 11 cases in the outbreak, so we're really limited by statistical power, honestly. I think if I look back on this now, I think probably it was transmitted through the date palm sap. But how do you know? We only know by evidence, and we had very limited statistical power, which is typically true in any outbreak. Let me just give you a short timeline of how long it took us to figure this out. So again, there were 4 outbreaks that happened between 2001 and 2004. The first clear evidence we had about how spillover was happening didn't happen until 2005. And we had enough evidence that where we were able to change some policy or have some clear policy statements about spillover in 2011. Okay? It's not a quick process. It requires diligence and a lot of very hard work to try to figure it out. Spillovers, we know in Bangladesh also happen, this virus also infects domestic animals. How do those spillovers happen? We still don't know. We're at the beginning stages of trying to understand this. So how did we figure those things out in Bangladesh? I'm going to give you a broad sketch to show you what we did. So first, we implemented some clinic-based surveillance in 3 hospitals across the areas where we'd seen outbreaks. This was led by the government of Bangladesh, of course. This is their mandate. ICDDRB was a technical partner, and we had a lot of funding from the US CDC. We tried to identify patients with risky exposure. So in this context, it was in the winter, so patients presenting in the winter time, because that's where most outbreaks were occurring. And we also paid attention to patients at some stage who had drunk date palm sap, or who reported they had someone in their family or community who had a similar illness. Right? If they came with encephalitis, then we had greater suspicion if they reported someone else had encephalitis in their community. We had, as quickly as possible, to screen them for Nipah. And then if they tested positive, then a spillover is detected. So we didn't wait for an outbreak. Of course, we're always looking for outbreaks, and those are a big concern, and we have to figure out what's happening. But we set up a system where we tested every single patient with encephalitis at the time of year where we saw Nipah, in the area of Bangladesh where we saw Nipah. It looks something like this. So in this map, you can see a number of spillovers. This is the locations of many spillovers that happened in the first decade or so. So we set up our hospital surveillance sites here. We looked for the outbreaks year-round, as I mentioned, but just in the winter, everybody with encephalitis got a Nipah test. We took blood, oral swabs, cerebrospinal fluid. We looked for antibodies and also Nipah RNA and oral swabs. We collected information about patients, clinical history. Of the hundreds of spillovers, we've had hundreds of spillovers detected through this route. Okay? Only 1% of the patients that are tested or less have Nipah. So it's not your typical surveillance at all. It's a rare event. It takes a lot of resources to do, and it's difficult. But I want to just show you here in this map, this was the first 10 years of the surveillance effort. We found more than 50 spillovers, but there were only 8 outbreaks. So what does that tell you? Almost all of the spillovers are one isolated case, just one. You're gonna miss it unless you're looking really, really hard for it. So if it's just one case, why do we care? Why should you look for it? All this resources, why? Well, one reason is you can understand then how the spillovers happen. If you're only looking at outbreaks, often as we know, even in Kerala, they're propagated by person-to-person transmission. So almost all the cases then are transmitted between people. How do you figure out how the first case happened? Very difficult to do after time. And again, if you think 11 spillover cases is small, with one spillover case, how many do you need to make some statistical associations with how that spillover happened? But when you find a spillover, it's a huge opportunity. You can do sequencing of that virus to understand which virus has spilled over. You can understand in more detail the clinical presentation. We've seen variation between outbreaks in Bangladesh. We don't understand why. Some have more features of encephalitis, some more of respiratory syndrome. The community investigations are very important. Contact tracing, understanding recent exposures, enrollment of controls for every patient. If you have the same case control instruments and you use them over time, then you can combine data over many years to get greater statistical power to understand how the spillovers are happening. And sampling of other animals is always key and very important. That's like the One Health investigation, like a symphony that comes together when you find a spillover to figure out how it happened. That leads to innumerable research opportunities as well. I just want to show you this. This is from 2005, when we finally understood the primary way, or we understood the first time really how we thought spillovers were happening in Bangladesh. So cases were 7.9 times more likely to reported drinking raw date palm sap than controls. And you can see the red line through here. This was the outbreak village. There was someone who was selling sap along this road, selling one glass at a time to the households on either side. When we looked at the line list of cases, all the cases came from different villages. And we thought, this is very odd. Usually they cluster together in one place. But then when we realized this road is going through and all the village edges are meeting here, and that's why the addresses looked different, but they had all this, most of the cases had this common exposure. So we got lucky in a sense. Obviously, it's never lucky to have an outbreak. That's not what I mean. But what I mean is that this was a clear-cut case that helped us gain some insight into what was happening. Then we had anthropologists and ecologists on our team. Again, it's a One Health approach. So we tried to understand, what is SAP? Why do people collect it? When do they collect it? We had to understand all those practices and also understand what the bats are doing. So you can see here, this was an infrared camera photo. We placed it in the trees. You can see the bat is licking the sap as it comes out of the tree. So we had to understand how bats are getting into the sap, because what do we want to do? We want to keep the bats out, right? So if we understand this is the pathway, then we can come up with the promises, right? What would we gain by doing all this hard work and looking for one single case, right? Here's what we can do. Okay, so there are golden needles in a haystack, I would say. Again, almost all the patients you test don't have Nipah, even in places where we know Nipah occurs. It's expensive to do, but this really helps us track things over time. So if you look on the right here, if you're tracking spillovers over time with the same frequency, then you can say something about how spillovers change year by year. In Bangladesh, they do, and it's really important to understand why. You can understand changes in cluster sizes, the geographic distribution, how that's changing, changes in the reproductive number, the proportion of cases who are transmitting, and also case fatality and symptoms. Because again, if we're concerned about not just what the virus does today, but what it could do tomorrow, you have to have some background understanding of what it typically does. You don't know what it typically does unless you're finding all the spillover cases too. Okay. I want to show you this, the spillovers over time. What do you see? Some years we have many more spillovers than others. Why? Why is that? Fascinating. What is this telling us about the ecological drivers of Nipah virus spillovers? As it turns out, we have many more spillovers the colder the winter is. So is that because the sap is sweeter when the temperature is colder? Is it something about the biology of the trees? We have some good evidence that people drink more sap when it's colder, for whatever reason. Is it increased virus survival? I don't think so, but it's also one hypothesis. But this helps us, again, understand what's happening and drive our research. We also can think about interventions. So we did a lot of studies then to understand how people collect sap, why they collect sap. And some of them used this kind of bamboo net to keep bats out. It was already being used by people there. So we developed some interventions and we trialed them to see if we could convince people to change their behavior and have safer practices. We also have primary prevention about just don't drink sap, raising awareness among people about how Nipah spillovers happen. There's plenty of sap consumption still going on in Bangladesh, of course. I mean, how many of us do everything the government tells us to do? Probably none of us. So, you know, that's not how behavior change works, but it's really important to at least have the message out there and to know and to make some important steps forward. So in closing, I would say, particularly to colleagues in Kerala, it's really, really difficult to figure out how Nipah is spilling over in any context. And I have a lot of sympathy for your predicament. Finding the spillovers is costly. It's also very bad news. Families also can't report exposures of patients very accurately. Most patients with Nipah die, so this is very difficult, right? Even just on a practical level to figure out. There are small sample sizes that limit your power to figure out associations. But I think I would propose that in at least our context, it was worth those difficulties because we learn more about the virus. The more we learn about how it's acting in different places, the better prepared we are for an outbreak anywhere. So you're an important next link in that chain for our understanding. You can target interventions, and I think importantly, you can start to reduce some of the fear because it's very scary, but at least if you can understand some of what's happening, it helps. I'll also plug the ASTMH annual meeting, which is later this fall. We're hoping to talk more about Nipah there, and you're all cordially invited. Thank you.
Thank you, Professor Emily, for the nice presentation. I know there will be a lot of questions about the research for Nipah. So it's a short question answer session. You can ask if any short questions just for 5 minutes, because there is a question answer session at the last for 20 minutes. And you can also type your questions and doubts in your chat box. So it's being discussed at the last time. But if you have any quick questions, we can go for that. Yeah, thank you.
It is a quick question, and thank you for a fantastic presentation. Quick question, and thanks for a fantastic presentation. How long did this research take? So part of it was retrospective, part of it prospective?
The team that I work with has been doing research on Nipah in Bangladesh 20 years, more than 20 years. And we're still learning.
Thank you. Yeah, phenomenal piece of work.
One more question, please, to add. Whether there is any evidence for respiratory route of transmission, given the variance of respiratory symptoms?
Good question. Anecdotally, yes. But that probably may have to do with the sort of the mode of transmission. The more likely you are to have cough, the more likely you are to have involvement in the lung. But I'm not sure that we know really well, because we also see transmission from patients who don't have any obvious respiratory symptoms.
Thank you very much for the talk. Probably a quick dumb question. Has anybody looked at decontaminating the sap?
So, millions, tens of millions of people drink sap every year, and most sap that's collected is actually boiled to make molasses. So only a small amount of it is drunk fresh. We looked into, could you pasteurize it? Is there something you could do to change the sap that would kill a virus? Those options would change the product itself. So could you do something to the sap to kill it, a virus? Yes, but then it would no longer be fresh date palm sap. So that's the conundrum. Okay.
I get some questions online.
Is there an online question? There's 10. I think most of those happened before my.
Just one question.
Okay.
Yeah. Anyone from online, you can ask questions, yeah.
They've put on the Q&A section. So
Yeah, okay.
you can read it out.
Okay.
So the question says, between 2001 and 2011, there have been greater than 50 spillovers, but only 8 outbreaks. What was detected as spillovers?
Yeah. So these are, this is a patient who presented to one of our surveillance hospitals with encephalitis, features of encephalitis, who had a confirmed Nipah virus infection. It was just, they're just isolated cases. Almost all Nipah spillovers in Bangladesh are isolated cases. In our experience, only 10% of Nipah patients transmit to anyone else. Only 10%. So if you find one patient who's transmitted, they're 1 out of 10. There are 9 others on average, maybe that you have missed. Okay, so yeah, they're just isolated cases, and they're happening all the time throughout the winters.
There are a couple more questions. The first one is, since people consume SAP even after notifying them about the issues, has there been any effort to modify the current SAP collection technique so that bats do not contaminate the SAP?
Yeah, and we may hear more about sort of these different options and policies from some of our speakers. There are, well, as I mentioned, we developed some interventions to try to change behavior of SAP producers to use this covering to keep bats out of the sap. We had a randomized trial that showed it kept bats out of the sap, which was great. But there are concerns about wide-scale use of that kind of intervention, because if you tell people you can drink sap, but only from that protected source, what if someone lies about it being a protected source? What if someone gets Nipah from drinking sap? Then, the government felt like, we want to tell people to be absolutely safe, you should not consume raw sap. So those were some discussions that we had about what is the best way to prevent. And I would say it's still a topic of discussion that we still have. How to best prevent, yeah.
There's one last question.
Yeah.
Do you think non-pteropus bats have a stronger contribution to the transmissions?
I don't think we have any evidence that they have any contribution. I haven't, at least I haven't seen it. I haven't seen it.
About last question.
I can just speak out loud. So you spoke a bit about how there's a trend to have a higher number of cases during colder winters. What sort of efforts, if any, do you have to kind of monitor the climate, our like weather predictions to, I guess, prepare for any higher load of cases in hospitals or anything like that?
So again, the outbreaks right now are quite small. So yeah, I don't think it's really a matter of surge capacity in any way. People where the Nipah surveillance happens, they know that it's Nipah season. They understand we've had interventions regarding infection control. So they're all engaged and they understand, you know, that winter is the time when Nipah happens. There hasn't been, as far as I know, I mean, I'm not on the ground anymore. I'm usually showing up here to work. So I don't know. I don't think they're targeting based on temperature really, because it's, I mean, the risk is there throughout the winter. So I think they just focus on the winter more generally.
Thank you, Professor Emily.
Thank you.
Yeah. I would like to welcome our Master of Public Health Program Chair, Professor Mary Dainer West. We are privileged with her presence for our talk. Welcome. We are going to the next talk.
Thank you, Dr. Emily. So I'm pleased to present our next speaker, Dr. Mahmudur Rahman. Dr. Mahmudur Rahman is the Country Director for the Eastern Mediterranean Public Health Network, Bangladesh office. He brings 36 years of public health experience, focusing on epidemiological research and disease control. He previously served as the Director for the Institute of Epidemiology, Disease Control and Research, and the National Influenza Center in Bangladesh for 12 years, where his efforts were crucial in developing the National Influenza Center, Biosafety Level 3, and the Nipah Laboratory. Dr. Rahman's career is marked by significant involvement in global health efforts, including key roles with WHO on committees for polio eradication, influenza pandemic, and the Nipah virus disease research and development task force. He currently chairs the Southeast Asia Regional Certification Commission for polio eradication and has 178 research publications to his name. His scholarly efforts have advanced public health initiatives, both nationally and internationally, and we're very honored to have him join us today.
Thank you. Thank you. Thank you. Can you hear me? And can you see the slides?
Yes, yes, you can.
Okay. Okay, thank you. Good morning, good afternoon, and good evening. Where are you from? It's a privilege, and thank you very much for inviting me to give a talk on Nipah in Bangladesh. And I would like to also mention that I was one of the collaborators with ICDRB, where Emily was working since 2004 as the director of the Institute of Epidemiology, Disease Control Research. So I'm still involved in the Nipah surveillance activities, which is still continuing. So my talk will be restricted on the Nipah Outbreak Investigation in Bangladesh, on One Health Partnership and Intersectoral Coordination. And I will give a story for this also, how it came up. You have already heard few of those from Emily, but just to keep you understanding that this viral zoonotic disease, bats of the reservoir, as you have heard, and pterosaur bats are the zoonotic host. Pigs are likely amplifying host, what we saw in Malaysia. And in Bangladesh, transmission is from bat to human and person to person. And the seasonality for outbreak is from December to May, which is the winter season here in Bangladesh. We can discuss more on this issue. And as you have heard that this first outbreak happened in 2001, but we didn't know that that was Nipah infection. We could know in 2004 only, and retrospectively we could identify in 2001 and 2003 outbreak was also from Nipah, as you heard from Emily also, the investigation she did. We started the surveillance activity in Bangladesh in February 2006. Until 2024, a total of 342 cases of Nipah infection were recognized, and as you can see that the case fatality rate calculated to be 71%, indicating a very high mortality. And when you have heard about the spillover, so far, I think it will be a little bit more now because this year also 2 cases happened. So it is 138 spillovers that we have counted. And secondary cases are about 46% of all the cases that has happened. And we have 86 survivors still we are following up. And these are being used for vaccine development also. We have identified 36 outbreaks, and affected districts are 34 out of 64 districts in Bangladesh. And you can see in the map how these are distributed all over in Bangladesh. And as you have heard that Nipah, if you look back in the history, where it came from Malaysia, and it is the name came from the name of a village there, Sungai Nipah, where first outbreak happened in 1998. And and if you look into the global picture, Bangladesh contributed here about 342 cases, from Malaysia and Singapore 276 cases, and India 137 cases. What we will be hearing from Kerala also, what they found, and from the Philippines 17. So these are the countries where we could identify Nipah, the 5 countries where we have identified Nipah all over the globally so far. And Bangladesh is the place where we are continuing to look for Nipah cases, and we are finding almost every year. And if you look into the transmission of Nipah, you can see that the ingestion of raw dead palm sap, as you have heard, and also partially bat-eaten fruits, but we couldn't confirm this that much here in Bangladesh, though this year we had 2 cases, but that was Nipah negative, where they had history of consumption of this, as you have heard, the boroi, the palm that is locally available, but those were found to be negative. But I had a strong feeling that this case could be from Nipah, but both of the patient died. So samples could be taken only from one, and that was found to be negative. Also the transmission took from person to person of Nipah virus. And this was from the patient to caregiver, or contact from the patient to the healthcare workers. So the objects used by the patient, and also during handling deceased. So these are the mode of transmission of Nipah virus in Bangladesh, what we could identify so far. So when we come to the One Health Partnership and Intersectoral Coordination, as you know, that One Health has become a very common thing nowadays after the Ebola and also this COVID-19 outbreak in tackling emerging infectious diseases. And in Bangladesh, we have practicing One Health strategy and partnership into outbreak investigation response since 2005. We can say that we have started using the One Health approach in outbreak in response, most of the outbreak investigation what we do. And in this partnership, the intersectoral coordination, there is a story behind the collaboration between the government and development partners and research organization in managing the Nipah virus outbreak. I will tell you the story, how it happened. And this story tells how cooperative approaches, a shared objective, mutual support, and persuasive cooperative, the problem-solving leadership may lead to strong collaborations amongst the many people and organizations in processing of creating a One Health platform to meet shared One Health objectives. And just to let you know, because there are a lot of students also there, what is One Health? One Health is an approach to disease prevention and control that takes into account the interconnections between human, animal, and environmental health. And the definition is also changing, which has come in a different way now. And in Bangladesh, where zoonotic infectious diseases like avian influenza, anthrax, rabies, and Nipah frequently emerge, a One Health partnership or strategy has been a crucial component of outbreak investigation since 2007. So this is a story I want to tell you. I don't know how you like it, but I think this is also quite important. I would like to mention the name of the people who were also involved at that time. I joined as a director of IDCR the Institute of Epidemiology discontinued research in October 2004. And Dr. Steve Luby, who was also at ICRB as head of the Program for Emerging Diseases and Vaccine Sciences and US CDC, Bangladesh country director, about the same time. And we met in a rooftop dinner party at ICRB and started communicating since then. During the investigation of Tangail outbreak, what you have heard is the Nipah outbreak in January 2005, where Emily was showing you. Steve, Emily, and I went together to the field with the Director General of Health Services and others. We had a large group when we were responding there. However, at that time, ICRB was investigating separately what happened in 2004. Then Steve, Emily, and I discussed and decided to work together as a single combined investigation team. And we formed collaborative multidisciplinary rapid response teams from IDCR and ICRB. So that is the starting point, how we started doing that. And in 2006, we decided to establish the surveillance system and do the laboratory test in Bangladesh. IDCR, ICRB, and CDC collaboratively contributed to the establishment of both the surveillance system and the laboratory. Then during the Nipah outbreak in 2007, we at IDCR and ICRB moved to the field together for the first time. And EcoHealth Alliance also joined with us at that time for the bat study. And the lessons learned from 2004 outbreak helped to foster our collaboration. So early detection was possible due to the establishment of the surveillance system, and early diagnosis was possible due to the laboratory setup in the country. And there was enough preparedness for the Nipah outbreak detection and response. Since then, IDCR and ICRB collaboratively and successfully investigated several outbreaks, and still this is continuing together. So in my perspective, there were three major contributing factors behind the successful collaboration. First and foremost is the leadership. Second, the division of labor, minimize overlaps and conflicts. And last but not the least, continuous exchange of ideas and discussions during and after the outbreak investigations, particularly during unknown outbreaks. So this is not only for Nipah, we are doing it for other outbreaks also together, and it went for quite a long time. So when we actually, and how we are detecting Nipah and how we are still doing that in our country. So we had an event-based surveillance setup in the country where we have hotlines, we have media monitoring, and also other informal reporting system where any outbreak or any unusual happening are reported through these hotlines. And also we also get information from different sources also from our own system of health service. That is the one part actually looking after the whole country. And in the Nipah surveillance system, we are restricted to not for the whole country. I will tell you how many sites we have and how we are doing that. So in this One Health approach, we involve the epidemiologists, the veterinarians, and the also environmental contamination assessment is also done. And we involve the anthropologist for the behavioral study. And also finally, we do the case control study also. So as you have seen in the Emily's presentation, that how the anthropologists help in understanding how the cases were distributed along the road when in the Tangail outbreak happened in 2005. So that from the first time.
Dicek dulu yang benar dah ya. Kalau udah dicek, dia semangat betul nih. Iya, nanti Pak.
Okay, can you? Okay, so as this picture you have shown in Emily's part also, the veterinarian got involved in this. In the odds ratio we found about 7.9. That we found that those who were drinking raw rat pump sap were getting the infection more, and that came from the 2005 outbreak. And after that, the veterinarian wanted to understand that how this is being transmitted from the bat, and they put infrared cameras in the bat, and you can see that there are videos also there where this was detected and how many times they were coming to this and how they were interacting with these trees actually and contaminating the sap when it was being collected. And this is only, it's not that all the bats are infected. That is the reason it is not happening that much. But if the bats are infected, so that is also an unknown thing happening when the bats are shedding viruses, which needs to be understood very well as yet. And also we see that there are areas where there are a lot of production of rodent palm sap, sap, but not much cases we could find in that area. But we know also that in that area they produce molasses a lot. But the raw date from consumption is still there, but that is also not very much understood why cases are not happening in that part. So currently, you can see that we have active surveillance in 8 medical college hospitals, where every encephalitis cases are detected and also tested. So this is enhanced actually during the season, when we say the season in the winter season. And you can see that the passive surveillance also in the 2 district hospitals, and enlarged surveillance also 425 hospitals. These are the sub-district levels and below. So altogether, the coverage is quite good in terms of the sentinel surveillance. But in addition, as I mentioned, that we have those event-based surveillance also, which is also capturing the cases, encephalitis cases which are happening. And also another thing which is happening now, that we are covering the whole country when the Japanese encephalitis surveillance is ongoing all over the country, and WHO is supporting that. So samples are being collected from the encephalitis cases. But unfortunately, about 90% of the cases are coming from the Nipah surveillance. The rest are from the rest of the country. So that is also one thing, but those are not tested for Nipah always. If there is an outbreak, that only happens. So we have the sentinel surveillance, laboratory investigation, outbreak and cluster investigation. If there are 2 cases, then we call it as a cluster. And there are also additional activities like Nipah survivor follow-up, support to this Japanese encephalitis surveillance, and testing of other pathogens causing encephalitis. And also we do data sharing with the development partners and also others, so that this can be disseminated well and also research can go ahead. So this is a slide where you can see that what are the risk factors we could identify so far from Nipah Bangladesh, from different studies, from the case control studies. You can see that most of these are Can you unmute yourself, please? So you can see that different type of hot tissue came up in different outbreaks. The last big outbreak was in Lalmonirhat, where it happened in 2011. And still now we are getting cases from one area where it's Faridpur and also Rajbari, where we get cases almost every year. So this is a picture showing that how we are identifying. So when we come to the implications of this, so implication is that you have already heard, but Bangladesh government has come up with only one message in 2012, and that was declared by the leader health minister, not to drink raw date palm sap. Unfortunately, people don't stop drinking raw date palm sap, and what we are gathering that this is getting increased nowadays with the movement of the people, and going also online. There is sale of raw date palm sap also nowadays. So WHO has included Nipah virus as one of the pandemic potential priority pathogen and has been included in the research and development blueprint of WHO. And this is also one of the implications from our findings all over the country and continuously generating data on Nipah. And we thank CDC also for supporting that. And as you know, the CEPI has funded 4 vaccine developers to come up with the Nipah vaccine. Efforts are being made by different researchers organizations to develop monoclonal antibody and rapid diagnostics also in line with that, so that this can be used actually when it is needed. So these are in the development stage and in the trial phase. Some has crossed, they are in the phase 2 trial. We don't think that we can go for phase 3, but this will be kept if necessary, then when the outbreak happens, large outbreak happens, then this can be used. And also, USAID has funded Stop Spillover project to prevent zoonotic disease in the animal-human interface, where Bangladesh Nipah has been identified as a priority disease. So these are the implications from which came from this, from all this surveillance system and also Nipah surveillance, what is gathering. So I would encourage you, I will share with you this, you can go to this website and see the video. I don't want to do it, this will take our time, but it's an interesting video where you will find the history of Nipah there and also a lot of information behind that. So thank you very much. That's all from my side, but I will wait for questions. Thank you. Over. I don't know who is moderating.
Thank you, Dr. Rahman, for your lovely presentation. Unfortunately, we're running a little short of time, so we're going to push all the questions to the end. I hope that's okay. And we're going to move on to the next speaker. So if you have any questions for Dr. Rahman, please hold on to them until the end of the session. Thank you.
Yeah, good morning, everyone. I'm Dr. Tarun Srivastava. I'm the co-director of events for Asia Pacific Public Health Network. And today I'm honored to introduce you all to Dr. Pragya Yadav, a leading virologist and scientist at the Indian Council of Medical Research, National Institute of Virology in Pune, India. Dr. Yadav heads Asia's first biosafety level 4 lab. She has made important contributions to the understanding and research of emerging viral infections, including the Nipah virus. With a PhD in biotechnology, her work spans across virology, biocontainment science, and public health research, contributing to the development of diagnostic assays and vaccines. Dr. Yadav's dedication has been instrumental in the timely identification and containment of outbreaks, showcasing her commitment to advancing virology and public health preparedness. Dr. Yadav, you can, we have your screen. Dr. Yadav, can you hear us? Yeah, your voice is breaking.
Can you hear Dr. Naveen?
Yep.
Dr. Naveen, can you hear me?
Yeah, now we can hear you.
Yeah, it seems some.
No problem.
Yeah. So I'm
Now we can
uploading. I hope. Yeah, thank you so much once again. And I would like to share the experiences of Nipah. Yeah, Kerala to share the public health response. So if we talk about the Nipah virus, as we know that it started in Malaysia and presented cases, and it took some.
Dr. Yadav, your voice is breaking. We can't hear you properly.
Detected in Bangladesh and It has give me a minute. Just connecting with another con.
Sure. I would like to apologize to everyone for the technical errors. If you could wait for like a minute or two.
The slides.
In the meanwhile, can we
Hi everyone. While we're sorting out the technical glitches, we can go ahead and take up questions for Dr. Rahman.
Well, hello, Dr. Mahmudur. Thank you so much for sharing your experience. You had mentioned about following up 86 survivors for the vaccine development. So could you please tell us the average survival time of the cases that's been followed so far and the average age of the population that's being followed up so far?
Actually, this is variable. It has started from 2004, actually, the outbreak that has happened. So it is more than, you can say, about 20 years. Some of them we are following up and still following up on a regular basis. And they have neurological deficit in most of these cases. And we collected samples from them also during this vaccine development stage. So we are still in contact with them. How they are doing and what's happening. But it is not that we have enough resources to go for a lot of investigations that couldn't be done. But they are with our contacts. So in different age groups now they are in. Over.
Yeah.
There's a question in the room.
Yeah, I can speak louder.
Yeah, I think the ceiling mics are on, so.
Thank you very much for your talk. Just have a two-part question. The first one is, could you please expand on the samples that you're collecting in terms of when you say collect samples, what's the protocol and what kind of samples? And the second one is, would you be able to expand a little bit about your animal studies and if imaging is a component on your animal studies as of now?
What is the component you said, the last part? Can you repeat it again?
Imaging. If
Imaging.
these animals have been imaged, yeah.
First question is that we are collecting throat swab samples and also blood samples we are taking. And we are taking subsequent samples also from the survivors to see the seroconversion. So that, and we follow in every outbreak, those who survive, we follow them and the contacts for 42 days. So these are standard protocol we have in here for doing this. Regarding the animal studies, we look for animal deaths in that area, if there is any. And in some of the cases, I can tell very clearly in 2007, some of the animals were exhumed also to take samples and test whether they died of from this Nipah infection or not. So those type of things. I don't think that the imaging has been done from the animals, that we couldn't go up to that much for that. But for the human cases, sometimes brain scanning is done, but not on a regular basis. We do that, the imaging for the humans sometimes. Over.
Thank you, everyone. We'll be taking the rest of the questions at the end. Now we'll be moving on with Dr. Pragya's talk. Dr. Pragya, are we audible?
Yeah, thank you, Dr. Naveen. Can you hear?
Yeah, we can hear you.
Yeah, and presentation is visible?
Yes.
Yeah, thank you so much for waiting for me. So I was telling that in India, so far we have recorded 6 outbreaks, and 2 of the outbreaks represent from West Bengal, and 4, the current outbreaks is from Kerala state. But we also know that Nipah virus has been presented widely in Bangladesh and also in the Philippines, and there are many countries at risk because of the presence of Terupus bats. As we all know that with the Bangladesh story and with the Malaysia, we could understand there were intermediate host and natural reservoir that included bats and pigs, and in Philippines, the horses. But India, it took some time to understand what is the reason for the Nipah transmission here in India. And so if we share the details of these outbreaks, the first outbreak in 2001, which happened in Jan to Feb in Siliguri, and that caused 66 cases and with 68% of the mortality. And the reason was unknown. In 2007, in Nadia, again, West Bengal, where 5 cases happened and all of them died with 100% mortality. The first outbreak, which was recorded in Kerala in 2018 with 18 total cases and with 88.8% of mortality. Though this mortality was very high and it shaken the health system, not only in the Kerala, but also in India. And that has led to a lot of efforts, and that has actually responded well in coming further outbreaks. And in 2019, there was only 1 case and there was no death. In September 21, only one index case, and though no further transmission happened. September, recently there were 6 cases and 2 of them died. And still, if we compare to earlier outbreak, the mortality rate is very low in compare. So the efforts which was made in state of Kerala was very important. If we look at the presentation of clinical in these outbreaks, in the first outbreak in West Bengal, it presented with fever, headache, vomiting, and altered sensorium was the major characteristic of the cases, and respiratory symptoms were presented in 51% cases. And it took 5 years. With the help of CDC US, we could identify the presence of Nipah in India. The very partial genome was sequenced from the urine samples, and they could match with the sequences from the Bangladesh, and it was far distance with the Malaysia sequences. And affected two hospital at that moment. It started from hospital and then it spread to the healthcare workers and also to the other hospital, and nobody had any clue that how this outbreak happened, how this index case was affected, and had a lot of unanswered questions. But that given it opportunity to think over that what we need to develop in India. And the first PSL3 was established in NIV in 2005. At the time, we didn't have any containment facility to handle Nipah like virus or any high-risk pathogen. And then after 2009 pandemic of influenza, the VRDL laboratories were launched across the country, which has reached 154 across the country to work on different viral diseases. With the time, it realized that we require a BSL-4 facility to work on viral diseases and further studies on vaccine therapeutics. And in 2012, a BSL-4 facility was established here. But we all again realized that Kerala didn't have a mobile BSL-3, and looking at the India's population and length and width, it was required to have a mobile BSL-3 which can be deployed whenever there is an outbreak, and we can work in such kind of setting. So in 2022, we could come up with a mobile BSL-3, which was used in a recent outbreak, and I would like to share quickly. So the second outbreak, which happened in 2007, presented with the fever and altered sensorium, and there was no further study we could do on immunology or other factor, but we could identify cases at very early. The genomic sequencing was done, and it was found that it matched with Bangladesh sequences. And further, it was one of a very shocking episode where everybody got affected and died as well. So the complete genome of this outbreak was available. In the third outbreak, when we started doing bat surveillance and we enhanced our activities in West Bengal, but for our surprise, next outbreak happened in Kerala in 2018. Cases presented with seizure, altered mental status, headache, myalgia, vomiting. Breathlessness was one of the major symptoms in this outbreak with the cough and fever. And that actually given the close contact list went up to 1,900, and which put Kerala state on a very situation of a severe situation to control the situation, to monitor, isolate the people, and also follow the patients. During the COVID-19, people has learned all these terms of isolations, burial, and how to but it was a new experience for India as such, and there was many challenges which was faced. Example, extreme fear of burial, mortuary were full with human remain, and there was no point of care assay which can be utilized at the field site, and there was no defined guideline or management. There was no treatment available, and there was also lack of sensitization of healthcare worker, isolation facilities. We used definitely the learning from Bangladesh, and Kerala government adopted many guidelines, which I'm sure Dr. Anish would even going to speak on that. But the first job was to training on dignified rituals and burials, then development of guideline and training of healthcare worker, and then establishment of stand-alone Nipah treatment facility. This was not all. There was a Nipah panic across the country, and there was a referral of all the cases who presented either with the respiratory infection or with the encephalitis. A large number of cases were referred, and they either tested positive for JE virus, rhinovirus, parainfluenza virus, adenovirus, and it actually increased more intensity to the current outbreak. As we know that we know that there is a kind of fact that half-eaten foods or urine samples can be also be treated one of the factor in transmission. People stop eating the foods, and there was a huge fear in the community. There were a lot of news which actually made anxiety among the community, and that actually given challenge to understand more what to do in such kind of outbreak where there is a high risk, there is a panic, and there is a fear of the death. So if we summarize quickly these, in 2001, we didn't have any test or assays. We didn't have any facility. In 2007, we had a facility, we could test quickly, but still we could not find the source of infection. If we talk about 2018 to 24 now, then further there was challenges of the burial, POCs, and other factors which we didn't address in the past. And then in 2021, then there was a COVID pandemic when two of the outbreak happened in 21 and 23, which added more problems to managing high-risk group of pathogen outbreaks. So there were some of the lessons we learned, and which was actually addressed by not only Kerala government, but as such the central government to deal with any such emergency, including the public communications and dealing with rumors, effective engagements of community, involvement of different stakeholder. And Nipah has presented one of the case where everybody has to work. We understand the importance of One Health and the high political commitment to deal with such disease. And to address this, we started working on some of the research need, and the first was strengthen surveillance, then point of care assay, and then we have to also work on the PP training, not only on the healthcare worker, but also the laboratory side, improving our response to such emergencies. And in that, we collaborated with one of the indigenous technology commercial and mall biodiagnostic. We work with them, we develop point of care, and we also received the emergency approval for using these assays for Nipah virus, and we constantly not used during the outbreak period, but also in the Nipah bat survey in the field to see how they are working and how they are performing. We are very thankful to Bangladesh that we went there and we tested these assay with them, and it worked wonderfully. Further, in 2018, we could isolate the virus from Nipah patient, and we could develop indigenous ELISA not only for the human, but also the swine and also for the bat. And they really help to understand more in India regarding the Nipah virus. These ELISA, in the past, we always has used the CDC reagent, which was shared by Dr. Stuart Nicole at that moment. And slowly we shifted to indigenous ELISA after validation and checking is the quality in here. The next question was to understand what should be the case definition of Nipah virus. The patients presented with acute encephalitis then the definitions was revised based on the different experience of outbreaks. And now we have added the respiratory involvement, myocarditis. Also, if there is a similar case in the family, neighborhood, at the workplace, and there is a clustering, there is one or more additional clinical criteria which may suggest Nipah viral disease. Breathlessness, cough, and many other factors which we observed were added in case definitions. The probable case definition was revised, and also the confirmed case was revised to address any suspected Nipah case in the zone. There was another challenge to find out what would be the right PP when you are handling the patient, or when you are collecting the specimen, when you are processing the specimen in the field. So we came the similar kind of PP which we used during the COVID was identified, because we also need to address the availability and also the financial need of addressing those kind of PP. In the next outbreak in 2019, the team was more prepared from the state and from our team, and this was only one case which was presented, and he survived, presented with fever, altered sensorium, and had no cough, breathlessness, had no further transmission of Nipah happened during this year. So during this period, we could set up a laboratory in Kerala state in a VSL2 setting using the paper. And there was a intensive training was done for the healthcare worker, and the state government took it at very serious task. And I think this training program which they did for Nipah really helped during the COVID time as well. So preparedness is one of the main key factors for high-risk pathogen, which we learned with the Nipah as well. And continuously laboratory training was done in Kerala and other suspected zones where Nipah was suspected. There was a multi-stakeholder response during 2019, though there was only one case. And these experiences we recorded and published so that other can also learn from our experience. We also could identify that what could be the right sample to be collected when there is a suspected case, and that included oropharyngeal swab, nasopharyngeal swab, urine, and rest of the sample. But these are the three samples which are present with the highest viral number for longer period in compared to other symptoms. In 2018, there was cases which were followed, and we found presence of semen viral RNA of Nipah till 26 post-day of illness. And we could see the Nipah viral detection up to 17 post-onset of illness in some of the Nipah survivor. Now the questions come if there is a asymptomatic transmission of the disease. And to understand, in 2018, there was a seroprevalence study was done. And out of 279 close contacts, including healthcare workers and community, there were only 3 found positive cases who are asymptomatic, and they presented positive for Nipah, IgM, and IgG. Further, this study was published, and in 2000, and further we followed the 2 of the recovered cases and 3 of the asymptomatic cases. And we could see that anti-Nipah IgM was detected from 5th POD to 49 POD, and then it turned to be negative. But IgG antibody persisted for more than 5 years. So that is another important finding which we could record. The different stakeholders' engagement in such kind of outbreak is the most important thing, which we learn and implemented in Kerala with the state government, and quick diagnosis, contact tracing, establishment of on-site field diagnosis, capacity building, and then augmentation of laboratory testing and the bat survey, which was the most important component to understand that how the virus is transmitting. In 21, during the pandemic, there was only one case presented with fever, altered sensorium, and no further transmission happened because of the early response, early detections, but there was many challenges during this outbreak. There was a lockdown, there was a high number of COVID cases in Kerala, and it was a time when the Delta wave was in very highly form present in Kerala. So we didn't know that when we are working in the field or in the isolation unit, who are the people having Nipah positivity, or if they, because the presentation was similar, they are having fever, cough, it could be Delta or COVID, or it could be a Nipah virus infection. So it was a very scary time for public health response and for the people who work. But at the same time, we did discuss how we can modify the diagnosis algorithm in a way that we can address these cases in not only in the Kerala but other part of the state as well. So there was an algorithm which was developed, and that included not only the bacterial endemic viral diseases, but also Nipah testing to be included so that we can address if any suspected cases come. So we started following the TrueNet point of care testing for Nipah virus, and then if they turn positive, then they can be confirmed by real-time PCR, and if they are confirmed, they can go for sequencing and also for the virus isolation. But if they are negative, then they should be ruled out for the AS pathogens and also the RI pathogens. So constantly, all the symptomatic cases were tested for AS and RI in all these outbreaks, and the endemic diseases were presented and found. The training of Nipah POC was conducted for different medical colleges of Kerala, and they are able to do this testing. Another point which I would like to share today with the audience, that the mobile BSL-3, which we validated in 2022, we tested many times in the field. So this facility has all kind of infrastructure which a BSL-3 should have, including the sample processing, testing, data reporting. And this facility was taken many times, even prior to outbreak in 2023, in Kozhikode district twice, and then other part of the Maharashtra state, to see that if it is functioning well, and if we can replicate the similar kind of data. And we also presented this in G20 meeting. And when this outbreak happened, the mobile BSL-3 and the entire team was deployed. So the suspected sample referred to an IV on September 12, 23, and this facility was deployed. It reached on site, and then it worked with Kozhikode Medical Center with Dr. Anita's team, and we provided on-site reporting to the state. And then there was a training conducted for the rest of the team there, and they could also work in this facility. And then after the outbreak was declared to be, there were no further cases and the incubation period over, then this facility was returned to us. So if we talk about this facility, the laboratory supplies, consumptions, it has a beautiful part that define PPE, material and sample movements, the movement of laboratory personnel, solid waste management, liquid waste management, airflow, surface decontamination, health monitoring of the laboratory personnel, their training, and the continuous validation of this facility was done before it was deployed to the site. This has also had a point of care, real-time PCR and LSI facility in Will, so that you can process any kind of samples. So if we talk about this current outbreak of 2022, there, as I mentioned, the first case, this was the outbreak where 6 cases happened. And retrospectively, we could confirm even index case, which was an age of 45 years, presented with fever, ARDS, altered sensorium, and also. And but initially, when this case died, nobody had any idea. But at the same time, there was admission of a clustering of the cases, including three members. And out of 3 of those members, 2 of the cases confirmed to Nipah. Further, one of the hospital contact of these got actually there was case 4 died, and there and then there was further hospital contact. They got infected, but they could survive, and they recovered. So if we talk about the presentation of these cases this year, they are having the fever, cough, ARDS, and seizures. Some of them presented with diarrhea, breathlessness. And so this is a kind of a very complex picture of Nipah, which are present in India. It doesn't have AES or it doesn't have only RI symptoms. So we have to monitor any cases presented in our clinical setting. This is some of the pictures of the mobile BSL-3 walking in the field where we are using pepper for walking. But if we talk about hunting for Nipah virus source of infection after 2001, so we started because the first outbreak happened in West Bengal. So we focus on West Bengal, and we did 3-year study continuously in not only West Bengal but also in Assam. And we found presence of Nipah in Pteropus bats, viral RNA, IgG antibodies. And in the meantime, in 2007, further cases happened in Nadia district. And we could study a different bat species in this, and we only found positivity in Pteropus medius. We, as looking at the history of peak engagement in Malaysia, we also tried to look at the peak serum sample from Mizoram state in Northeast, but none of peak samples so far being found positive in any of the outbreak, and in these in the West Bengal or other area as well. Then we started doing countrywide sero of Nipah, looking at the situation in the Kerala, and then we could see not only the bats are positive in Kerala, but they are also positive in West Bengal, in Assam, and many other states, either for viral RNA or they are mostly present positive for IgG antibody. But at least in the Kerala and in the Northeast area, they are having viral or RNA positivity constantly. So this was another observation. And if we link the bat positivity with the outbreak, so just for the audience, in 2018, when we did the bat survey during the outbreak, the Nipah viral RNA positivity was 25%, not only in the throat swab, but also in the rectal swab. And this was the highest positivity which were recorded in almost all the study. But in 2019, 21, 23, constantly we could see viral RNA positivity and also IgG positivity. There was a question about other species. Initially, when we did a sero survey in bats, we never found Raucetus bat species positivity. But from 2020, we also could see in Maharashtra state and other state, in Kerala also, the Raucetus species positivity for IgG antibodies. But when we did a PRNT for Nipah virus, only Pteropus bat showed actually neutralization with the virus. So that is another things to understand, that what kind of other possible viruses may causing antibody in Raucetus species as well. If we talk about the genomic sequences, so far in India, we have two genomic lineages which is present. In Kerala, we have named as I genotype, which is different than Bangladesh, but in West Bengal and other state where bat were found positivity, they go very close to Bangladesh and having more similarity with the Bangladesh two genotypes. Further, if we look at the recent sequences from Kerala, again, the recent sequences are matching the sequences of earlier bat sequences and human sequences positive from Kerala outbreaks, and not with the West Bengal sequences. So the two genotypes are at least circulating in India. So we are working on a strategic intervention for Nipah disease preventions, because at the moment we all know that there is no vaccine available. And the major challenge for us is to find out how the virus is transmitting from bats to human, because in Kerala, in different outbreaks, we could not find that there is a SAP engagement is there. There is no peak engagement in there. And we tested large number of fruit sample in and around the index cases and the people who died with Nipah. Another challenge with the Nipah outbreak in Kerala, that almost all the outbreak happen in the rainy season, and we don't know if all the fruits and everything get washed out with the rain, and we are not able to get any positivity. So this question still remain, and we are further working with the One Health Center of the Kerala and state government of Kerala to understand the risk factor, and hopefully in future we'll have some answer. But also we are working on the laboratory sending and trying to work on vaccine monoclones and other diagnostic. And we are open to any collaboration if anybody has any any thought to work on this. Recently, India has launched One Health mission, and we are working with the different stakeholders across different sector of the government and also the private industries, because this is the most important lesson everybody has learned in COVID pandemic, that we have to work together. We have to leverage the capacity from one sector to another. And in this model, we are also further working on surveillance, syndromic surveillance, addressing the acute encephalitis, myocarditis, hepatitis, respiratory illness, acute fever, and acute diarrhea. And the first AAS surveillance would initiate very quickly across the country. Another challenge which we are trying to address, the respiratory virus surveillance in bird sanctuaries, using the different stakeholder on the same line of One Health mission and try to address. So if we look at the requirement of R&D for Nipah, definitely we require a vaccine, preventive vaccine, which can help and can be given to the healthcare worker, the people who work on the virus in BSL-4 and containment facilities in the laboratory, so that we can on exposure we can save their lives. But also we should have monoclonal antivirals for Nipah virus, which can use as a treatment mode. Then we all know that India has a capacity and pharmaceuticals at large, and if we have any product, it can be easily replicated and make in a huge capacity. There are a lot of other experiences, but respecting the time, I would like to thank the partners from Government of Kerala, that include Esther, GMC Codicode, GMC Ernakulam, ICRA hospitals, and Health Minister, and a very strong commitment of state, NCDC, EMR, Ministry of Health, and the team from ICMR, including the leadership from headquarters and BSL-4 team from NIV. The Bangladesh who help us in validation of our kits, including ELISA and also the real-time PCR. With this, I thank all of you for patient listening, and my apologies for internet not working very well. But if there is any question, happy to answer it. Thank you very much.
I would like to extend my heartfelt thanks to Dr. Pragya Yadav for her insightful and enlightening presentation on the Nipah virus. We will take questions towards the end as we are short on time. Now I would like to call Lipin to take it forward from here. Thank you.
So our next speaker for today is Dr. Anish T.S. Dr. Anish is currently serving as an additional professor in the Department of Community Medicine at the Government Medical College, Kerala, and as a nodal officer for Kerala One Health Center for Nipah Research and Resilience. Dr. Anish's expertise spans various critical areas, including epidemiology of infectious diseases such as Nipah and vector-borne illnesses. He is deeply committed to understanding the intersection of health, climate change, and geographical factors, a pursuit reflected in his extensive research and fieldwork. As the nodal officer at the Kerala One Health Center, Dr. Anish leads initiatives aimed at enhancing understanding of Nipah virus dynamics and bolstering community resilience against such threats. Furthermore, his pivotal role as the convener of the State Experts Committee for COVID-19 underscores his commitment to mitigating contemporary health crises. Dr. Anish's remarkable educational journey includes a Master of Philosophy in Clinical Epidemiology and a Doctor of Medicine in Community Medicine. Additionally, his pursuit of knowledge led him to attain a postgraduate diploma in public health and a PG diploma in health economics, healthcare financing, and policy. An impressive researcher, Dr. Anish has garnered recognition for his scholarly contributions with an H index of 18 and 51 index publications to his name. Please join me in welcoming Dr. Anish.
Thank you. Am I audible?
Yes, Dr. Anish, you are.
Yeah, thank you. Thank you for that introduction, dear Lipin. And is it visible? My slides are visible, I think.
Yes.
Yeah. So I would thank the organizers for keeping me in the loop. And I am rather thankful to Dr. Pragya Yadav for her presentation because it is very easy for me to go through the journey of Kerala. And one other thing is Dr. Pragya's research on these aspects has contributed much to the learning that we have got from Kerala. And I am happy that so many colleagues are there from Kerala joining in this meeting. So as Dr. Pragya mentioned, we have got 4 spillover events starting from 2018 and 2 outbreaks. Just like Dr. Emily mentioned in the first speech itself, all spillovers are not end up in outbreaks in Nipah. In Kerala, we have got 4 spillovers and only 2 outbreaks. Outbreaks are in 2018 and 2023. In 2019 and 2021, we ended up in a single case. So to see where Kerala is, you can see the graph, and it is the southern western part of India. And I will just show you. Okay, now I think you can see it very closely. That Nipah outbreaks were concentrated more towards the northern part of Kerala, especially the district of Kozhikode. So you can see that there are 4 spillovers, and out of the 4 spillovers, 3 happened in Kozhikode, only 1 district. And there was 3 hospital-based super spreading. So this particular patient may be going to some hospitals, and there will be clusters in that hospitals. And in 2018, we have got 2 hospital-based clusters in Kozhikode, and 2023, we have another hospital-based cluster at Kozhikode. And another thing is, we have conducted some research in bats by the leadership of Dr. Pragya, and we identify Nipah virus, not only virus, the antibodies against Nipah virus in 6 districts. We have got 14 districts, and out of the 14 districts, 2 districts we have got Nipah outbreak, Kozhikode and Ernakulam, and we have got virus in 6 districts in and around these epicenters during the outbreak season. So other 18 districts, there were no surveillance in bat samples. So that may be the reason that we were identifying only Nipah virus in 6 districts. So as Dr. Emily has already mentioned, Nipah is a paramyxovirus. It is notorious for its host tropism because it is infecting the highly conserved B2, B3 receptors. So even if we have got a notion that Nipah, the intermediate hosts are there for the Malaysian outbreak, and we do not have intermediate host for Bangladeshian outbreak or outbreaks in Kerala, definitely we have to look into the possibilities of intermediate host, because in laboratory, Nipah used to infect many mammals because it is infecting a particular receptor which is very conserved. So there is high possibility of intermediate host for Nipah. So we have to be very keen about that. And as far as we know, the samples that we have got from human beings as well as in animals, that is bats, we were identified to have a unique cluster in Kerala that is named as NIVI. So that is according to Dr. Pragya and her team, this particular virus is highly pathogenic, and it has got the cellular toxicity level is much high, and it is even comparable or more than that of the viral strains that we have identified from Bangladesh. So what we are understand from Kerala, that Kerala could be an epicenter of a group of Nipah virus. That means this particular area may be the home of this kinds of virus maybe for a pretty long time. So as we have mentioned, and we heard from Dr. Pragya that they were able to identify the virus as well as antibodies from bats, especially the Pteropus medius. and they got samples from different samples, that is oral swabs, rectal swabs, blood, and internal organ. But very rarely they could find viruses in oral swabs. And rectal swab positivity was more common than oral swabs. And they were able to identify antibodies in blood and in internal organ, especially in spleen and kidneys and liver. They were able to identify the live viruses or the viral RNA. So that is a very important finding for us, because rather than we are concentrating on the fruits and all other beverages licked or by bats, the rectal swabs are also very important. So the fecal contamination is a very important risk that can have. Another thing is, as the internal organs has got viral presence of virus, if there is some predator animal, and these animals can act as intermediate host. So these kinds of things are very, very important in Nipah. So whenever we are thinking that there is no intermediate host for Nipah in Bangladesh and in Kerala, but definitely there is a chance of some domestic animals to be act as intermediate hosts. And when we were discussing these things to our friends, especially friends from veterinary side, they were suggesting to investigate on cats, because cats has got a habit of eating bats, and some intricacies will be there, and we have to look what is happening around us. Is there any intermediate hosts are there between human beings and bats, and helping the virus to spill over among human beings. So as far as we know, human beings are accidental hosts. And the nature of infection is of three types. One is the direct spillovers from natural reservoirs, that is from bats. In Kerala, we don't have any pattern identified for the mode of spillovers, because as Dr. Emily has pointed out, most often it will end up in a single case, and that person may be died at the time of when we are detecting the case, and at least that person will be very ill, so that we cannot ask that what happened or what ended up in a spillover. So transmission mediated by intermediate host is documented in Malaysia and Singapore, that we do not have evidences from Kerala and Bangladesh. But another important concern is hospital-based super spreading. So these patients will be bringing to hospitals at the time of the highly infectious stage of their disease. And there is a chance that other patients and other caregivers or even healthcare providers may be infected by the virus. So if you look at Kerala, out of 27 spread or transmissions happened, 20, that is around 75% of cases acquired the infection through a hospital-based super spreading event. So that is a very important thing, that if you are able to safeguard your hospitals from spreading infections, either to the caregivers or to the patients or to the healthcare providers, we may able to reduce the burden of Nipah very dramatically. So in Nipah endemic areas, definitely we have to concentrate on hospitals. And if there is a highly infectious patient suspected to be having Nipah, just like an encephalitis or ARDS, definitely we have to have highly suspicious and we have to isolate the patient. Otherwise, the outbreak will grow like anything. So this is a very important thing, that in Nipah, based on the Kerala experience, the hospital-based super spreading should be prevented. Because if you are able to prevent hospital-based super spreading, most of the infection could be prevented. And another one is healthcare workers can be protected, because they are very important workforce. And the spread of disease could be prevented at hospital, because hospital is a hub where people from different places will assemble. So if there is a spread is happening at hospital, the disease can transmit in a faster rate to very different localities. And another thing is, according to the natural history of Nipah, the maximum transmission will be towards the later part of the disease, when the patient is very, very ill. So the chance of getting a hospital-based super spreading is very high, because the patient will be highly viremic and symptomatic when this patient reaches to hospital. So there are many collateral benefits also there, because it will, if your hospitals are protected, definitely it will give protection to many other infections. And another thing that we have noticed from hospital is that our hospital caregivers, especially doctors and nurses, are not wearing proper protective measures. That is a very important thing. That in Kerala, whenever you are looking at CCTV footages, what we are seeing that the patient wearing masks are protected. The patient unprotected interaction with the patient is definitely it is a risk. So that is a very important point that we have to have in our mind. Another thing is the importance of structural changes in a hospital. This is a graph from the study conducted by Dr. Arun Kumar et al. Regarding the first outbreak of Nipah in Kerala. So what you are seeing in the picture, all are either hospital wards or some localities in hospital, very crowded places, and how the transmission is happening in these crowded places. What you are seeing in the left-hand side, left lower part is a hospital ward, and what you are seeing in the middle, here, it is a crowded place near the CT room of Calicut Medical College. So the infrastructure of the hospital is very important. So whenever you are dealing with infectious patients, there should be enough air circulation, and there should be an isolated area to keep these patients. These points are very important to mitigate or to reduce the total number of infections in Nipah. This is a very frequent question that we used to ask, because in India, why Kerala? Because Kerala is somewhere around 2,000 kilometers away from the identified epicenter of Nipah, that is Bangladesh or West Bengal. But we are getting cases, but other states of India may be spared. From Dr. Pragya's lecture, it is clear that there are viruses are there detected in bat samples in many parts of India, but human cases are reported only from Kerala, at least for the last 6 or 7 years. One reason maybe Kerala has got the best health indicators in India, and our health system may be better to identify the cases. Because to identify Nipah is the system should have some capacity to identify Nipah, because most often it will end up in single cases, and it can be an unknown death, unreported, that can happen. Second one is, even if there is clusters, the cluster size will be very small and the duration of the entire outbreak will be short. So the health system should be informed that this kind of an issue is there. Wherever the pteropus bats are there in Asia, we have to strengthen the health system so that to detect early cases of Nipah. That is actually something that we have to think of. And the health system is more efficient to detecting spillovers of encephalitis cases or deaths. That is another thing that may be applicable for Kerala, because Kerala has got a dedicated system. Dr. Pragya was mentioning about different checklists and different guidelines that government of Kerala is already given in the context of Nipah. And we have got a system to screen encephalitis cases and acute respiratory distress syndromes. And another thing is, as Dr. Pragya was already mentioned, this NIVI, that is the particular type of virus that may be emerged in Kerala and may be circulating in some part of Kerala. That could also be a possibility. So these are some very important things that as we have got only 4 instances and only 2 outbreaks, definitely our sample size is limited. And case fatality of primary cases or the spillover events is somewhere around 75% in Kerala. And if you look at the patients who did not receive antiviral treatment, the fatality was found to be 100%. But it is only 61% for the patient who received antiviral treatment. So this is actually a sum total. It is not a single outbreak. It is the whole 4 instances and 2 outbreaks together. So this is an importance of an antiviral treatment to reduce the mortality of Nipah. But some people argue that if the disease is very fatal, sometimes the physician may not identify it is Nipah, and the physician may not get time to start the antiviral treatment. So there will be some bias in these analysis. But when we are eyeballing things, the antiviral treatment appears to be having some protective role in Kerala. And if you just look at the mean reproduction number, so the index case or the primary case has got high reproduction number. Reproduction number means how many people are infected from a single person. We have got 4 spillovers, and these persons who received the infection from the natural host could able to give the infection to another 22. But the secondary transmission was very, very low. The first person will be receiving, 4 people were receiving the infection from natural sources. They are giving the infection to another 22, but all these 22 were able to produce only 2 additional events. So at the end of second wave, the outbreak is going to cease. That is why the ideal or a typical Nipah outbreak is a very small outbreak, end up in a very small number of cases, and the entire outbreak will be finished maybe in 1 or 2 weeks, or rather a month, because there are no tertiary cases or quaternary cases. If an infection is happened from the index case, and one more infection can happen, but it will cease. That is the pattern that we notice. But the problem, if this virus has acquired some mutation, and if it is becoming more able to transmit among humans, this pattern can change. That's what we have noticed in COVID-19. And that is our nightmare, that this can happen to start a pandemic. So that is a very important thing that we have to notice. And another thing is, in 2 instances in Kerala, as we have already mentioned, we have got only 4 instances. In 2 instances, we were not able to isolate the patient before the start of respiratory symptoms, and it ended up in additional 22 cases. But in another 2 events, especially in 2019 and 2021, the patients, the primary cases were isolated and there was no transmission. So detection of cases and isolating it early is very, very important in Nipah. So if you are able to isolate the patient soon after the detection, and if you are able to detect it very soon, definitely the transmission rate and the outbreak size will be much low. Okay, another thing that we have noticed in 2023 outbreak is that case fatality is much low. Out of the 6 individuals, only 2 died, somewhere around 33%. But in 2018, in the previous outbreak, we have got a case fatality somewhere around 90%. So what led to the reduction in case fatality this time? Many factors could be there. Is there any virological factors? So Dr. Pragya's research is showing some light that there is no much changes in the virological factors. The virus that ended up in an outbreak in 2028 is almost the same that we have got now also. Is it early detection and supportive care? That may be an important thing that as a community or as a health system, we are able to pick up cases early now because of our previous experience. And that might have ended up in a lower reduction or a lower case fatality. So we were using antiviral drugs extensively, especially remdesivir. Remdesivir was introduced to the schedule now by the state medical board through a amendment of the medical practice in Kerala. And one physician who managed a patient using remdesivir told me that if you document the time of the remdesivir is given to the patient and the clinical improvement, you will wonder, or you may exclaim that you may think that remdesivir may be a wonder drug. So these kinds of antivirals may be having a role. According to Kerala experience, what we think that the non-specific antivirals given in a compassionate ground has got a role in reducing the case fatality of Nipah. And that may be the reason that this time in 2023, we were able to reduce the case fatality to 30%. And another thing is monoclonal antibodies, but we've never used monoclonal antibodies. This time, as we have got more survivors, we are trying to get or to conduct some research to develop some monoclonal antibodies. And Dr. Pragya's team is also conducting a lot of research on that field. So another aspect, as Dr. Emil has already mentioned, the ecology and climate is a very important thing. And compared to Bangladesh, what we have observed in Kerala, our cases are happening in peak summer. It is not the winter, but it is summer. We don't have a large winter season in Kerala, but it is happening in summer. All cases occurred between May and September, that is the summer season, and the fruit bearing season, that is something that we noticed is not in winter but in summer. And some people argue that this is the season for mating and childbearing for bats, because during childbearing season, to protect the young one, maybe in utero, the immunity of the bats may be under-regulated. That may be a reason for that. Some people argue that even we have got papers from Bangladesh that El Nino Southern Oscillation events, just like a temperature anomaly that is happening in Pacific Ocean, is something related to these kinds of events. That is temperature anomaly, extreme temperature. Just Dr. Emil was already mentioned, if there is a reason, there is a very cold winter is a reason for outbreaks in Bangladesh, is very hot summer is a reason for outbreak in Kerala that we have to look into. Because if you look at this is the graphs of the extreme summer in 2021 and 2023, and we can see that a dot that is in the black circle, that is really corresponding to the epicenter of Nipah in Kerala. So these areas were exposed to high temperature events. It is actually not in the direction of that of Bangladesh, but in the reverse direction. Hot summer was observed in these areas, both in these years. And we were looking at the data of Kerala Disaster Management Authority for the last 10 years. And this particular area, that is the Kozhikode district and Kozhikode-Wayanad intersect, is an area where there is a high chance of temperature anomaly in Kerala. That is the place with highest temperature anomaly in Kerala. As far as Kerala is concerned, we have got a lot of strengths and maybe weaknesses. One thing is that our political commitment is enormous, that as Dr. Pragya has already mentioned, the health system definitely can detect spillovers, and optimum health system and social response is there. High level of awareness among people is actually a merit. And we have got guidelines and protocols in place. We have got a very good private-public coordination, because in most of cases, the cases may be identified. First case may be identified by a private hospital. That is a usual pattern till 2023 outbreak. 2023, our field workers were able to identify the first case. And the National Institute of Virology and its field station is helping us a lot. And now we have got other institutional mechanisms are also there to support the initiative. And this is an interesting office order that it is, you can see the date in Malayalam. The date is 12th September 2023, one day before the disclosure or of the outbreak this time. So even before the case was detected to be Nipah, the government started 19 teams to investigate and to work in the field. You can see the 19 teams may be involved in many different areas of outbreak management was working. So these kinds of a system response is there in Kerala that may be helping us to limit the number of outbreaks, but still we don't have, we do not know what is the reasons for spillovers, and we do not know how much spillovers are prevented because of our initiatives. So we have got many weaknesses, and one is we don't have known behavioral factors, just like that of date palm sap or something like that in Bangladesh. We don't have that kind of a pattern in Kerala. We don't have date palm sap collection in Kerala. We collect toddy from coconut trees, but it has got a different mechanism. The bat cannot enter to the vessels. That is the nature of that collection mechanism. The high burden of virus in natural reservoirs, as Dr. Pragya has already mentioned, at the time of outbreaks, we were able to identify that 15% of our bat population is positive for antibodies. And we have got limited laboratory-based screening in the field, and climate change may be an issue because we have got a hypothesis that extreme weather events may be contributing to the outbreak. And the research activities are there to an extent, but we have to pick up. And now we are started collaborating with the National Institute of Virology and ICMR and many other people, including our local self-government, to initiate some resilience mechanisms so that we can prevent spillovers and we can detect outbreaks early, and we may be able to contribute to the pandemic preparedness for the entire world. And as Dr. Emil has already mentioned, as it is a disease with a highly potential to have another pandemic, definitely we have to work together and keep the world safe. Thank you. This is our team, surveillance team, along with our minister. And this is not the whole team, but this is the small team looked after the surveillance activities. Thank you. And I am thankful to Dr. Shaji, and he is there in our office of Kerala One Health Center for Nipah Research. Thank you.
Thank you so much, Dr. Anish, for the insightful talk. Next, we will be moving on to the Q&A session. I would like to invite Dr. Emily onto the stage for the Q&A session. And I would like to hand it over to the moderators for the session.
I'll pretend the other speakers are here. We have seats for each of you.
Thank you, dear speakers. It has been a very enlightening session for all of us, and we are very grateful that you have taken time very early here in America and late evening back in Bangladesh and India. And we have a couple of questions. We are over time, but I think for our own knowledge and for all our interests, let's continue with the question answer sessions. So we have one question from Dr. Sumit Garg for Dr. Pragya. Does the epidemiology of Nipah disease warrant development of vaccine? If yes, is ICMR thinking of partnering with vaccine manufacturers for the development of Nipah vaccine? Over to you, Dr. Pragya.
Thank you, Dr. Sumit. It's a wonderful question. And as we all know that Nipah is one of the high priority disease and given priority by WHO. And CEPI has given a 100-day mission, one of the priority disease in that too. So ICMR is definitely very serious about all kind of therapeutics and also the vaccine, because if we have a vaccine, we can protect the healthcare worker, which is the major force while treating the patient. And though we know that Nipah, as Dr. Anish mentioned, that it doesn't have a reproduction high number, but as we have seen in the COVID, we don't know if it can change, mutate, and increase the transmission. So having a vaccine would be very ideal for today and also for the future preparedness. Thank you.
Thank you, Dr. Pragya. The next question can be answered by any of our experts today. How is the surveillance of animals being carried out right now for Nipah? Maybe Dr. Emily can take it right now.
Sure. If we're talking about like a routine surveillance program, there's nothing like that ongoing in Bangladesh. We have a research study that we've started where we're looking for serological evidence of infection and seroconversion. So some identification of which animals are being infected when in a very limited area for our research purposes, but not a surveillance platform per se. Although I suspect if there were a large outbreak, there might be some testing to investigate that, of course.
Excellent. Any perspective from our India team?
So currently, we are focusing on bats because that was the first question to know that how much bats are infected, what is the range in country. So we are focusing on that, but we are going to do a study with the Kerala government now, which we have discussed recently and got the funding, where we are going to look at the people who are engaged in working on tardy part, where they are working, and if the seropositivity of those people, and also looking at the bat positivity in the same area, and then try to link if there is an outbreak happen in prospective future time. So this is a study we are looking forward, but we are not doing any any animal testing or surveillance currently, because unless we get a clue, it will be not a good idea to test randomly. So if we get the identify the factor and any animal, then I think yes, then it will be make more sense.
I wanted to make a comment, if I may. Sorry, I'm looking at the audience, but I really want to see the faces of the panelists, so I'm turning around. Dr. Anish, I really I appreciated your highlighting the seasonality of human cases in Kerala. And I wanted to add that in Bangladesh, we have a very strange situation, actually. When we find a human spillover case, if we rush very quickly to the bat roosts nearby that case, we can find bats shedding, sometimes a lot of virus. If we set up longitudinal surveillance over time in a bat roost, it's very hard to find bats shedding. But when we do, it's usually in the summertime, at the same time when you find your spillover cases. It's a mismatch with our seasonality because our human cases are in the winter. So we find bats do shed then, but if we're looking over time, it's very difficult to find. But it does align with the seasonality of your cases, and I'm just wondering, in longitudinal assessments of bat shedding in your area, is that also when you find bats shedding more? Well, that's the question, I guess.
Yeah.
Yeah.
Again, we have got some discussions with Dr. Pragya's team exactly on this particular question. So what is happening to our bats over the seasons? So now we know that there are positivity in bats in the areas of outbreaks and during the outbreak. That is the thing that we know now. It is, as I have already mentioned, it can vary from 3% to 25%, just like Dr. Pragya has already mentioned. So what happened across the season? Definitely, it's a very important question for us that definitely we will look into, and we will have maybe publications on that when we meet again. And another thing I want to add on the previous question about the intermediate host, that the virological analysis and the epidemiological analysis should be combined. Otherwise, the problem is the animal can be a victim. Sometimes it may not be an intermediate host at all. Just like a human being is affected by Nipah, an animal can also be affected by Nipah. That doesn't mean that the animal is acting as an intermediate link between the bat and the human being. So the epidemiological study combined with an virological analysis may be able to bring some light on these things, but definitely based on some clues, just like Dr. Pragya was already mentioned.
Thank you, Dr. Anish.
So just
Dr.
I
Rahman,
do.
please go ahead. Anybody has a question? Dr. Rahman, please go ahead.
Yeah, thank you. I just want to bring up here for the Indian team, and also what we are getting a little bit of other things like in addition to the raw date mumps and consumption, these are the fermented sap also, which are being used. So maybe that can also be looked into. that whether those are playing any role there. When you take the history of food consumption, or whether they are having anything like that, that can also help in understanding, just to let you know.
Yeah,
Can I have a
just
question, sir, to Dr. Rahman?
Yeah.
Sorry, Dr. Pragya. Can I?
Yeah, please go ahead.
Yeah. You mentioned about the epidemiological studies, especially case control studies, has got very high odds ratio in favor of date palm. Is there any instances where you were able to find any viral RNA in date palm? That is the first question. If not, is there any instance where you were able to find any viral RNA in any of the environmental samples?
Yeah, we looked for that, but we couldn't find virus in the date palm sap. Emily can also shed light on that. But we actually we found the biological plausibility that we found in the bats infected, and we found in the human infection, and we found the consumption history, and we repeatedly found this type of history in different outbreaks. And finally, we concluded that this is coming from the consumption of the raw date palm sap. So epidemiologically, we are bring that link, but in this, we couldn't find virus in the sap, because if you have to do that, we have to do a huge number of sampling to find that, because it is not very common. It happens once in a while. So we don't know when it happens, and when we get the human cases, by that time those SAP are not there to look into that. Emily, you can add something if you want to. Over.
Yeah, well, our lab colleagues would understand very well if you're proposing sending thousands and thousands of samples of date palm sap for testing. Lab colleagues aren't very excited about that because we know the chances of finding it are very low. And really what we want to know is, was there Nipah in the sap that was consumed, by the time you're doing the investigation weeks ago? So, even if you don't find it, it doesn't tell you anything about that pot of sap, which is really the main issue. So we've tried it, but we didn't pursue it that aggressively. If I may, I have a burning question for the 4 spillover cases that you've identified in Kerala. I think they were all male, if I got that right, which could be by chance. Who knows? Do they have any exposures in common, as far as you know? Over.
Now, Dr. Professor Emily, actually, we were trying to identify any of the common exposures. One was a child, a pediatric child in 2021. I think it is a 13-year-old boy. And in other instances, it is men, maybe middle-aged men. In 2019, it was an youngster. But never, they were not using any toddy or date palm sap. And some of them were religiously prohibited of using such drinks. So we were not able to find any of the links. And some people argue that some of that is 2018 and 2023, these people were having some kind of skin lesions on their body. And some hypothesis is that they were using some leaf or some local medication for the remedy for those skin lesions. That so many hypotheses are there, but we couldn't find anything common in all these 4 aspects. Only thing that we were able to identify that in 2018 and 2023, the 2 spillovers ended up in large outbreaks were happened in a very small geospatial area that is somewhere around 10 kilometers just away. So it is just like in a very, very common area. It is just around a forest that is known as Janagi Kadu. That is actually a reservoir of so many bats. And one side of that forest, we have got a case in 2018. In the other side, we have got the case in 2023. Other than that, we were not able to identify anything common in these 4 spillovers.
Yeah. Just a point to add on the original question which was asked regarding, so in Kerala in 2023, we did a survey in bats and that included the month of Feb, July and September. So these were the month and they are under 40 kilometers of range of the cases which happened in the past and which happened in the currently. And we found that not only the affected area where the cases happen, but also the Wayanad, which is never reported the cases, the positivity of bats were there in both the area. And in all these months, definitely we could found constant IgG positivity, but the ratio of IgG positivity and viral RNA was very high in the secretion when the outbreak happened. So that was a very there was another thing which we noticed that in the month of Feb, when there was no outbreak, the tissues, example, spleen and kidney were positive in Nipah, though there was no secretion in throat swab and rectal swab. So these are some of the observation which, and if we look at the West Bengal cycle, which is more likely matched with the Bangladesh outbreak happening in January, February, April, but in Kerala, the month of outbreaks from May to September. These are the month actually where all the cases happened. So these are the month at least we can say having the high risk. But looking at the February presence of the viral RNA in bats, again, creates a lot of questions. We need to do more, maybe every month sampling to see that what are the seasonality, secretion, and other factors too.
Thank you so much, panelists. We have just one last question, and this is from Dr. Pranab Chatterjee. Since there has been several Nipah virus survivors, is there any role in exploring convalescent plasma as a treatment mode? Is there a risk of carrier status in Nipah virus? This is mainly asking Dr. Rahman and Dr. Yadav.
Okay, we don't think that they are shedding any virus. We didn't find that experience there because they were tested afterwards also. So it is not, but we have not found any relapse even also. That was also looked for, that whether there was any relapse of Nipah virus infection or not. It is not that. The other question, as you have asked about whether these can be used for treatment purpose, I think Dr. Yadav can answer that, or Emily. I don't think that we have tried for that. But these are used for vaccine development, obviously. Over to you.
Yeah, thank you so much. So using the convalescent plasma as a therapy would be a very difficult question at the moment because Malaysia has shown many recurrence of Nipah a presentation of, and they could, even one of the paper, they could show the antigen presence in the Nipah virus after 6 months, 2 years, and after. So that's actually a risk. So we don't know till we have very clear-cut idea. But in so far the cases which we have studied, we did not see. But I think we need more data to try for such kind of therapy. Maybe Dr. Emily can answer if she has some experience. But most of the treatment, which one of the CDC paper, which I remember, after using the remdesivir, they could still look at the neurological sequelae in animal models. So that's another problem which we see with these cases. Even though if they recover, then how they will end up and what kind of viral hiding where we have no idea. The Nipah is very less studies so far, I can say.
I think there are some
yeah.
infectious disease specialists in the audience, and they can answer this question.
I think Dr. Emily should give her comment.
Well, I was just going to mention that, you know, the monoclonal antibody therapies are based on this idea, right, that this could be a good therapy, and those have been shown to be useful in animal models if they're given very early in the onset. So we have less, you know, we don't really know in humans, but as Dr. Yadav said, it's not just a mortality outcome that we're concerned about. It's not just about survival or death. does the patient do well? And those are questions that are very difficult to answer. Yeah.
We have one question from the audience, and I would request it to be brief. Two, I think. Please be brief because we are already half an hour over time. But let's just take the questions.
Greetings to all the Spark experts. It was a very informative session. So we can see there were many Nipah outbreaks that happened in India, and you mentioned some spillovers. You mentioned Nipah virus occurring more in the summer as opposed to Bangladesh. So in Bangladesh, the spillovers occur mostly through Dr. Gurley's presentation. But you mentioned that there are not much rodent pump saps in Kerala. So will you share how the spillovers happen in India throughout different places?
So the question was about how the spillovers are happening in India because of the less use of raw date palm sap. It would be nice if somebody from India team can answer it.
I can say something, and I think Dr. Pragya can contribute more. Frankly speaking, we don't have any very clear-cut data or idea of why this is happening in Kerala. And here in 2023 outbreak, that index case or the primary case, that person had a farm along with his house. And we were able to identify many bats foraging in that site. And in 2018 also, there is some hypothesis that the person who got the infection first has got some interaction with some forest area. And in 2019, even the ICMR team, NIV team was able to capture bats positivity in the dwelling place of that person got the infection. We visited as a surveillance in 2023, we visited the house of the person who got the infection in 2021. And that was also an area where there is so many bats were there. The only thing we were able to identify that the people affected were coming from areas where the bat infestation was huge. But we were not able to identify any mechanism of spillover or any particular behavior that was ended up in this particular spillover. That is the finding that we have got from Kerala, and I am not aware of the researches done in West Bengal. Thank you.
Yeah, thank you, Dr. Anis. In West Bengal in 2001 and 2007, when outbreak happened, that time even we didn't know the bats are engaged in India. So that was a kind of very early research. But in later on, when we did a survey in West Bengal, we found the Nipah viral RNA and IgG positivity in bats. In 2012, the first time we could see, then in 2015 to 17, we found the multiple time positivity in West Bengal as well. But if you look at how it happened in Kerala, we don't know, because we tested all the fruits, we tested different things which everybody thought suspected, but we don't have any positivity or any evidence. And even social scientist study in 2018 could not reveal much out of whatever information is there in public domain which we publish. So this question is still remain with us, that we are still working, thinking, and if anybody has any idea. And but recently we did a webinar and we invited different ecologists across the country, and some of them, most of them actually suspected different kind of fruits, nuts, maybe when they are which is around the houses, and if the bats are eating or the bats are urinating, and if they are infected, they are touching, and if it is getting entered through the mucosal ways or through the eating. So these one of the factor which we take as a high risk, but we don't have evidence to prove. So that's the one factor, but rest is unanswered and we are still looking for it. Thank you.
To add what Dr. Pragya was saying, in Kerala we have got only 4 instances, but in Bangladesh we have got 50 instances. In Bangladesh, they could prove the role of date palm sap through case control study. Even the earlier studies were even negative for date palm sap. Never we were identifying the virus, presence of virus in dead palm soup. So you just collect all these evidences together. We may not able to identify virus in any of the natural samples. But if you are able to conduct some case control studies, you may get some etiological clues. But for case control studies, you should have good numbers. Then only you will get a statistical power to get some identification on a particular risk. So Kerala, we have got only 4 instances, and Nipah 4. There never we could identify the reason for spillover in this much limited number of cases. So that is quite natural that we are not able to identify, but in future. But luckily or unluckily, if you are getting more cases, we may identify, but we hope that there will not be much cases, because every time we are trying to prevent spillovers. That is our role.
I totally agree with you. We don't want to see any more cases.
If you allow me just 1 second, I think I reported 138 spillover. Emily mentioned up to 50, but as of now, it is a little bit more than 138. The other point is that we do case control study on a regular basis, and we take 3 times of the case against 1 case, the controls. And based on that, we do the case control studies when we get outbreaks. So this is a regular practice we do. Over.
Yeah. And I would note that we aggregate those cases over time. So even the first 4 you have, you can have some, you have at least 4 already, I assume, and you can build if the unfortunate situation arises.
To conduct case control study also, it is very difficult, because we have got, suppose 25 cases of Nipah in Kerala, but we have to identify those people who got the infection first, because the other people are getting infection from person to person transmission. So we have to identify enough survivors. Then only we will able to identify the spillovers. Even we have got only 1 spillover case survived in Kerala. So we are actually do not having any chance of conducting a real case control study to identify the risk factor. The only thing is that we can do, we will go for some epidemiological studies, and we will try to identify some presence of viral or antibodies in environmental samples or animals. So that is what we are proceeding with the National Institute of Virology. That is what I think.
Thank you so much. And with respect to time, I understand there are still questions in the audience. We would be very happy to provide you with email addresses, and if necessary, we can set up a Zoom if our panelists are available at another time. But for now, it's time to say goodbye and to have some breakfast. I would ask the president of the Student Assembly to come up on stage and give the vote of thanks. And prior to that, I would ask the president of APPHN to acknowledge Dr. Emily Gurley's presence today with us. All APPHN officers, we would be very happy if you could come on stage so that we can give a token of honor to Dr. Emily. We are very proud to have nearly 100 audiences across the globe with us today for the past 2.5 hours. And it is an extremely wonderful response from the globe across. So we are very happy, and I'm pretty sure we should have more sessions like this, and especially when we have more questions bubbling. Over to you, Ashok.
Thank you all, distinguished guests and esteemed keynote speakers, and my dear friends and colleagues. Today I stand here with an esteemed gratitude and profound responsibility to show our heartfelt appreciation to this illuminating discussion on this emerging threat in our region. So first, my deepest thanks to our keynote speakers, Professor Emily thank you for the sharing of your groundbreaking research in the Bangladesh and your insights of the complexities and the challenges in investigating Nipah virus spillovers deepens our understanding of the more understanding of this emerging threat. And Dr. Mahmudur Rahman, Dr. Pragya Yadav, and Anish T.S. Despite the distance, thank you. We felt the impact of your expertise. Dr. Mahmudur Rahman, your tireless work and your health initiatives in the Bangladesh serves as an inspiring model for the intersectoral coordination. And Dr. Pragya Yadav, your dedication to understanding the emergence of the Nipah virus is very vital. Your perspectives of the preparedness, response strategies, and future considerations are very critical to safeguard the Nipah virus, for the future safeguarding our region. And Dr. Anish T.S., thank you for sharing the invaluable experience of the how you dealt with the Nipah virus in the Kerala, and the resilience of your state. It offers a guiding light for our future preparedness. And also, we wish you good luck for the Nipah Research Institute, which started in the Kerala government. We hope it will bring a lot of change about the Nipah virus. And for the all APHN members, especially the President, Dr. Naveen, we appreciate the effort you are putting for organizing this event. And last but not the least, all the participants who came here and involved in this discussion, we appreciate. And you gave us an enriched, multi-faceted knowledge about this Nipah virus. And let us carry the spirit of this discussion to our respective fields and transform this into the action. Thank you.
Thank you very much, and bye-bye, everyone.
Thank you. Bye, everybody.
Bye.
Thank you so much.
Thank you all.
Thank you, ma'am. Thank you, everyone.